All right, today we're jumping into the incredible world of precision neurosurgery. We're talking about a field where the technology and the strategy are so advanced that a single millimeter can literally change a person's life forever.
So let's just start with the biggest question of all, the one that really defines this entire field. When you are operating on the most complicated object in the known universe, the human brain, how in the world do you do it perfectly? What does it take when there is absolutely zero room for error?
And this is what really drives home just how high the stakes are. We're not talking about inches or even centimeters. We're talking about 1 single millimeter. That tiny distance can be the difference between a full recovery and losing your hearing, or the ability to smile, or even your memories. That's the razor's edge these surgeons are walking every single day.
Okay, so the first big challenge is all about vision. How can a surgeon, when they're removing a tumor, be 100% certain that they've gotten every single last cell? Because, leaving even a few microscopic pieces behind can change the entire outcome for a patient.
And this quote, well, it gets right to the heart of it. Gross total resection. That's just the fancy term for getting the whole thing, every visible bit of the tumor. And what's so critical here is that a patient's survival, their long-term survival, often comes down to the surgeon's ability to do just that.
So how do they do it? Well, this is where the technology gets really cool, almost giving surgeons superpowers. They've got something called neuronavigation, which is basically a GPS for the brain to guide their instruments. Then there's intraoperative MRI, which gives them a real-time map during the surgery. Raman spectroscopy can tell them on the spot if a piece of tissue is cancerous or not. And my personal favorite, fluorescent markers. It's like a special paint that makes only the tumor cells glow. It's all about making the invisible enemy visible.
But what happens when taking out 100% of a tumor is actually more dangerous than leaving a tiny bit behind? This is where the surgeon's job gets even more complicated than you can imagine.
So picture this. You have a benign tumor. It's not cancerous. It's called a vestibular schwannoma. The good news is it's not going to spread. The bad news, it's tangled up with the delicate nerves that control your hearing and your facial muscles. If a surgeon goes in too aggressively to get every last cell, they could cause permanent damage. It's the ultimate surgical dilemma.
And that brings us to this really elegant solution, adaptive hybrid surgery, or AHS. Instead of this all-or-nothing approach, AHS is, well, it's a strategic compromise. Surgeons go in and carefully remove the main bulk of the tumor, but they intentionally leave the tiny part that's stuck to the nerve. Then they come back and treat that little remnant with super-focused radiation. It's a two-part plan where the patient's quality of life is priority number one.
And when you look at it like this, side by side, the benefit is just crystal clear. With total resection, sure, the goal is to remove every cell, but the risk of nerve damage is much higher. With adaptive hybrid surgery, the goal shifts to safely removing most of it, which dramatically lowers the risk to your hearing and your smile. The outcome isn't just about getting rid of the tumor, it's about preserving who the patient is.
Okay, let's shift gears now to a totally different kind of problem. With something like epilepsy, there's usually no tumor to see, no lump to remove. The problem is hidden in the brain's electrical wiring. So, how do you operate on a problem you can't even see?
Well, the target actually has a name. It's called the epileptogenic zone, or EZ. This is the one precise spot in a person's brain where their seizures start. And what's wild is that it's unique to every single patient. The whole point of the surgery is to find that one specific zone and either remove it or just disconnect it from the rest of the brain to stop the seizures right at their source.
To find that zone, surgeons have to become like medical detectives. And they have this whole toolkit of clues they can use. High-resolution MRIs might show a tiny, subtle change in the brain structure. Video EEGs let them record a seizure as it's actually happening. Functional MRIs show which parts of the brain are firing up. Every test is another clue that helps them zero in on that one tiny target.
And just when you think they've cracked the case, there's another twist. What if their investigation leads them to the right spot, the epileptogenic zone, but it's sitting right next to the part of the brain that controls language or memory? Now what? You can't just go in and remove it without causing a whole new, devastating problem.
This is where they do something that's basically a surgical test drive. It's called WADA testing. What they do is inject a temporary anesthetic that switches off one specific part of the brain for just a few minutes. And while that area is offline, they test the patient's speech, their memory, their motor skills. By doing this, they can create an incredibly precise map of all the critical areas to avoid, making sure they can protect those functions during the real surgery.
So all these principles, seeing the invisible, tailoring the surgery to the person, mapping the brain's functions, these ideas aren't just for tumors and epilepsy anymore. This intense focus on precision is kicking off a whole new era for all of neurosurgery.
I mean, just look at stroke. For years, everybody knew the treatment window was a strict 4.5 hours. That was it. But now, by using advanced imaging to see exactly which brain tissue can still be saved, doctors can actually treat some patients up to 24 hours after a stroke. That is a massive, life-altering amount of extra time.
And this is a perfect example of a huge shift from being reactive to being proactive. With aneurysms, we now have new imaging that can spot inflammation in an aneurysm's wall, which tells us it's unstable. This lets surgeons go in and fix the aneurysm before it ever gets a chance to rupture, preventing a catastrophe before it even begins.
And it's happening in pediatrics too. The whole approach is getting more fundamental. So for conditions like craniosynostosis, where a baby's skull bones fuse together too early, surgeons aren't just treating the symptom anymore. They can now identify the specific genetic issues causing the problem, which opens the door for much more targeted, much more effective treatments down the line.
And that really brings us to the final big thought here. We're seeing neurosurgery move away from these one-size-fits-all procedures and toward treatments that are perfectly customized to a person's unique body, their specific disease, and even their DNA. It just leaves you with this amazing question. As this trend continues, as surgery becomes perfectly tailored to each and every one of us, what will we be able to heal next?